Expertgruppen för biståndsanalys, EBA, är en statlig kommitté som oberoende analyserar och utvärderar svenskt internationellt bistånd för att det ska kunna förbättras och utvecklas. EBA har 10 ledamöter med kompetenser från olika biståndsområden och ett kansli som verkställer besluten. Förutom våra rapporter så ordnar vi seminarier, workshops och möten mellan olika parter. Varje år sammanfattar EBA sin verksamhet i årsberättelsen Biståndsanalys. Den kan beställas från kansliet eller laddas ner på eba.se. EBA har ett oberoende i relation till uppdragsgivaren regeringen, liksom i relation till vad som utvärderas, samt till de rapportförfattare som anlitas. Rapportförfattarna ansvarar själva för slutsatser och rekommendationer i sina studier. Allt vi producerar som rapporter, seminarier och vår podcast EBA-podden finns tillgängligt på vår hemsida.
Very good. So let's begin. So today's seminar is what we call a DDB seminar. DDB stands for Development Dissertation Brief. And it's a seminar where we invite persons who have recently defended a doctoral thesis in areas that are of relevance and interest for the expert group for AIDS studies. And as I said, today we're going to discuss, we will be in the sort of emergency and humanitarian crisis domain. We are very fortunate because we will have introductions to 3 different theses that are linked and that sort of complement each other. We will look both at the situation of people directly affected by disasters, the individuals affected by disasters. We will take a step back and look at how a health system manages to interact and support people affected by disasters. And then we will take an even further step back and look at what we call disaster risk governance, which is sort of the whole system and all the bodies in a country dedicated to reduce the risk of disasters. And as you saw from the film, the 3 theses have been sort of summarized or abbreviated in short versions that you can find on our website. We will begin, and just let me say before we introduce the thesis, if you will be invited to ask questions and comments, and please use the Q&A function to do that, and you can begin posting your questions already when you hear the introductions of the 3 theses. So we will begin by inviting Jenni Koivisto, who has defended her thesis at Karlstad University in October 2018. And the name of her thesis is Navigating in the Midst of Uncertainties, Challenges in Disaster Risk Governance in Mozambique. After that, we will come back and give further introductions, but we'll then listen to Anneli Eriksson, who will talk about needs assessment and needs estimates. And then finally, we will listen to Dell Saulnier, who will talk about health system resilience in Cambodia. But please, Jenni, the floor is yours.
Thank you. Okay, so I will talk about challenges in disaster risk governance in Mozambique. Next slide, please. Right, so disasters often place very heavy burden for societies, making them an important development issue. And because of that, disaster risk reduction has been emphasized more and more. However, it has proven quite difficult to conceptualize, to organize in practice, and to govern. And when we have the complex disasters, we often need all sorts of different knowledge. And because of that, more and more sort of multi-stakeholder and multi-level and polycentric strategies to DRR have been advocated. However, the more we have stakeholders involved and more we have so different arenas for decision making, it brings new sets of uncertainties and challenges. Next slide, please. So what I wanted to investigate was to look at the uncertainties as perceived by those actors that are actively involved in disaster risk governance in Mozambique. The main question was to how does the multi-stakeholder disaster risk governance and the various uncertainties therein affect DRR policy making in Mozambique. It's a qualitative study. I did my fieldwork mainly in 2013 and 15. Next slide, please. So it's about Mozambique in Southeast Africa. It's very prone to different natural hazards. Can you advance the slide? Thank you. There are a lot of floods, mainly along the big rivers that cross the country on their way to the Indian Ocean, and also along the coast, where there are also tropical storms occasionally make landfall, causing devastation on the coast. Also a lot of droughts, and sometimes also at the same time droughts and floods in different parts of the country. There's also been increasing seismic activity, but not so big disasters yet related to that. But starting from the independence in 1975 to 2018, there were 74 natural disasters reported, if we use that word. There are about 30 million people living in Mozambique. Most of them live either on the coast or along these rivers, making them very much exposed to hazards. Many of the people are very poor. Many live on subsistence agriculture, making them very vulnerable in the face of disasters. Next slide, please. So I wrote a compilation thesis based around 4 articles or studies. And the first study, I looked at the long-term development of DRR policy in Mozambique. And I identified different barriers, but also sort of enabling factors that have influenced the DRR policy process. And the study kind of gives an overview of different uncertainties and challenges, but also possibilities that have been there. And the second paper focused on stakeholders and stakeholder involvement. So I wanted to know who is involved, how did they coordinate their work, and what kind of sort of prevailing policy disputes there might be. And I noticed that there is kind of a divide in how different stakeholders or actors understand disaster risk reduction, where for some of them think it's more so purely disaster response and recovery issue or preparedness. Others see it more connected to climate change, and yet the third group kind of sees it as a development issue, focusing on issues like vulnerability reduction. Next slide, please. No, there was one missing. Can you go back a little bit? There. Right, the third paper focused on staff turnover. And I wanted to know how stakeholders perceive staff turnover and how does it affect the disaster risk governance. There is a very high staff turnover in the organizations involved in disaster risk governance and DRR activities in Mozambique, with obviously it's affecting the work. Here I would like to make some sort of a conceptual distinction between I'm still at the earlier slide. The type of mobility, whether it's external or internal, where the external mobility is more what we think the people are just completely disappearing from the system. This is often very challenging for the system, whereas then the internal mobility refers to mobility where people move from one organization to another, but stay in the system, still work on the DRR issues in Mozambique, which is not bad at all for the system. And the last paper focused on participation, and I wanted to know whose voices are not included in decision making. and kind of contrast the practice in Mozambique to these calls for all of society engagement for DRR that, for example, the Sendai framework for DRR has been advocated. And it reveals different obstacles for to wide participation. Next slide, please. A few points that I would like to discuss more relate to capacity and capacity development, whether we should focus on individuals or systems. It's very obvious in Mozambique that there's been some very skillful individuals who have played a key role in policy development, and their work has really kept DRR high on the agenda. However, there are problems with capacity retention. We know there's a high staff mobility, which kind of brings the issue of that the knowledge may be lost. And so, for example, if we have capacity development programs, we should have to make sure somehow that the knowledge remains in the system, even if individuals might move. Another point is about the recurrent disasters. Disasters are obviously very devastating often, but they can also be positive in the sense that they open space for learning and changes to occur. However, if you have a lot of disasters, they kind of lose their shock value in the sense that, and we might not have this sort of window for change. And Mozambique is very much sort of stuck in the sort of preparedness, response, recovery cycle. They hardly even recover from the previous disaster when the next one hit. And it's difficult to then kind of look beyond the next disaster and think sort of more long-term incentives. And also that a lot of the funds become available only when there is a disaster for response and perhaps early recovery, and less so for more long-term DRR. The third point I'd like to lift up here is related to the multi-level and multi-stakeholder approach. Although the international agreements, for example, have been very good and are very influential, they also kind of mean that a lot of the decision-making power remain outside of Mozambique, which can cause some challenges. I also think that there is a disconnect between these different levels, starting from the international, regional, national, and then provincial, district level, local level. At least in Mozambique, the subnational level remain very weak still. Next slide, please. Finally, some concluding remarks. There are a lot of uncertainties relating to coordination, collaboration, information sharing, and the inclusion of different stakeholders in decision-making processes. The capacity remains quite low and it's sort of fluctuating. There are limited resources and disagreement over what DRR really is about and who should be involved. And because of these issues, the long-term DRR interventions have been quite limited in Mozambique. And I also think there is a sort of increasing disconnect between theory, policy, and practice. Theories are moving on, policies come a bit after, but there is limited capacity and resources to implement the policies often, which is a problem. And I also think that this all highlights the importance of integrating DRR and vulnerability reduction in all development strategies across the sectors. And I would also like to highlight the issues of power relations, accountability, and transparency. I think they deserve much more attention. Next slide, please. Yeah, I will finish here. Thank you very much.
Thank you, Jenni. there. Thank you very much. This is a really interesting thesis on an extremely complex issue, seemingly simple, but a very complex one with many actors with different kinds of motivations and roles in society. So the floor is open for a couple of minutes if anyone would like to ask a clarifying question. Anything? I don't see anyone in the Q&A box. So if there are questions, we will come back to that later for the general discussion. Now let's then move to Anneli Eriksson's thesis. Anneli defended her thesis estimating needs in disasters very recently, only this summer in June, at the University of Bergen in Norway and at the Center for Research on Healthcare in Disasters at Karolinska Institutet. So please, Anneli, the floor is yours.
Thank you, Johan. Yes, so this is this thesis, estimating needs in disasters. As Johan said, it was presented at the University of Bergen, and maybe we can move on to the next slide. So while I'm on a daily basis, I'm working with the Karolinska Institutet, but this was also, it was work done in collaboration with Bergen University. And the studies were financed by the Swedish International Development Cooperation Agency, SIDA, for the first two studies, and by the Swedish National Board of Health and Welfare for all three studies, so Socialstyrelsen also. Next slide, please. Yes, so all of our presentations are mainly, it's focusing around disasters, so maybe I don't need to go very far into this, but just to say a few things in the introduction, which is that while we may think that disasters are occurring, are rare events that occur every once in a while, but they're actually, I mean, on a daily basis, people are living and suffering in disasters, and they affect more than, well, up to 200 million people every year. And this is if you count in then that they arise due to natural, man-made, or mixed hazardous events that interacts with vulnerability, exposure, and coping. And so a disaster is basically characterized by unmet needs and lacking resources. We can move on to the next slide. Yeah. So, as I said, disasters require external and often international disaster assistance, and most of that type of assistance is provided through humanitarian assistance. And as we know, humanitarian assistance should be guided by the humanitarian principles. And there, the impartiality is one of the core principles, of course, stating that assistance should be guided by needs. And also funding of humanitarian assistance should be guided by needs, also clearly stated in the good humanitarian donorship that was elaborated in the early 2000s. But to that, there are, of course, a lot of challenges, and one being that there's a discrepancy between needs and available resources in many settings, meaning that needs also, we also have to be guided by the proportion of needs if we want to remain impartial in a way. And also, of course, there is a problem of data, patchy data, and a lacking tool for analysis, a tool to be able to actually compare the needs, the proportion of needs between different types of disasters. Next slide, please. So the aim of my thesis was then to increase the understanding of what factors contribute to disaster severity and how they can be measured in order to estimate the scale of needs in disasters. And the thesis is based on three studies or three papers, and the first two are looking to estimate needs in complex emergencies, conflicts, and other types of man-made protracted disasters. And the third one is looking at possibilities to predict needs after earthquakes. Next slide. So the study setting for paper 1 and 2, complex emergencies, is it's sort of in the humanitarian sphere, it's an old term by now and maybe not used so much anymore, but the way that I've understood it and used it in the papers is that it's a situation where the mortality among the civilian population has increased significantly compared to the baseline due to or direct or indirect causes of conflict, such as malnutrition, spread of communicable diseases, or where governmental policies contribute to the development of a disastrous situation, such as food insecurity, malnutrition. And basically, what we have been using, or what I have understood as complex emergencies in this case, are countries that are also being part of the consolidated UN appeals or the humanitarian needs overviews. And so data in the studies have been taken from the appeals and also from open databases. Next slide. So, and then study paper 3 on earthquakes. The reason for actually focusing also on earthquakes is that they are the deadliest type of natural disasters that also generate a significant number of people in urgent need of life-saving humanitarian assistance. And so in this study, we included data from the Université Catholique Louvain, their Center for Research on Epidemiology and Disasters, that has an emergency event database. So we looked at all the earthquakes included between the year 2007 and 16, and compared this against the GDAX alert database and looking at earthquakes with a magnitude over 6.5. So in total, we looked at 226 earthquakes in 55 different countries. Next slide. And in order to measure needs in disaster, in order to find indicators that could help us to lead to the proportion of needs, I was using this theoretical framework published by Binban and Sudnes in 2003 and then adapted in 2015. And it is a very general framework that is being used in many different settings, in disaster risk reduction, in resilience, and so on. And so basically what it says is that a threat of a hazard to happen may lead to an event, may lead to damage depending on how many people are exposed, may lead to needs that can lead to a disaster. But there are factors that can sort of prevent, modify, or help people to cope, and I mean, remaining resilient, that are all, I mean, portrayed here in green, that I think when we talk about disaster risk reduction and resilience are the important factors. But there's also others that may increase the risk for disaster, vulnerability such as poverty, health problems, etc., on an individual basis. And there also exposure, the number of people that actually are exposed is of course an important factor. So if we take the next slide. So in the first two papers, I focused on finding indicators that could help us to measure the level of severity and needs based on vulnerability, exposure, damage, and the number of people affected. And next slide. In the third paper on earthquake, as there I was trying much more to predict after something happened, what would be the predicted needs or the predicted severity of a disaster. We also searched among vulnerability indicators, exposure, and we used damage and affected as outcome measurements in this one. Next one. So in paper 1, or the first study, It's based on a literature review, matching of indicators with the use today in indexes and consolidated appeals, a ranking of the indicator, and then to design a model based on this theoretical framework, where we selected a final set of indicators and elaborated cutoff values. And so from first hundreds of indicators, we boiled it down to 22 that were actually available and used. And out of those, the selection, we selected 4 vulnerability indicators and 2 for exposure. And then if we move on to the next slide. So in the next paper, I say we all the time, but I should say I, of course. I applied this model that I had developed on 25 contemporary complex emergencies to see whether data was available, which it was, and also to see whether we would sort of have if the model was working as a guide on severity and on needs. And so in the first graph, you see the yellow is the severity, where Somalia, a Central African Republic at the time of the study, so 2014-15, were the most severe, had the most severe situations together with South Sudan, Afghanistan. But then looking at the needs, where we also included the number of million of people in needs, of course, other countries also amounted to higher needs because of the number of people affected, Yemen, for instance. Now, there were also variations between the countries over time, and the last picture shows, or the last graph also shows the correlation between excess mortality and our model, which is almost a perfect correlation with recently finished conflicts in the world. Next slide. Now, on the third paper, we weren't as successful. We actually didn't manage to find any indicators or models that could clearly predict the level of needs. And so also, I mean, none of the indicators and also none of the multivariate models did actually improve these results. So it was a study with no results, basically. Next slide. So with this, what are the possibilities? Well, we think that there are indicators for vulnerability and exposures that point to the needs in complex emergencies. And you can actually make use of a very basic model with few indicators and still allow for, I mean, that can give you possibilities to use the data in an objective manner and to comprehend and compare the scale of needs in complex emergencies. And the caveat then is that the lack of correlation between the tested indicators and outcome after earthquakes is an important caveat, as these indicators often are used in risk models and risk indexes. Next one. I think I'm getting close to the end now. Of course, there's many questions on this, and so we've been using big data, country level, and there one can question if it doesn't hide sometimes the severe vulnerability and the needs in smaller parts of a country. And of course, vulnerable groups versus a total population-based data. And this is, I mean, there are a lot of other aspects of vulnerability that the model doesn't capture. And then again, using mortality as an outcome data is, on the one hand, stated as I mean, it is the thing that you can measure against, but on the other hand, it's a very late sign of needs and severity. Next slide. So, policy future research. I think as this started as discussions from a funder perspective, and I think that there are different ways to go ahead with this, but it shows that the study shows that it is possible from a donor perspective to make your own analysis, or you can also base judgments on more elaborated indexes and UN appeals. The study that we made and the outcome that we had, if you make a brief comparison between the UN appeals and funding, it shows quite a clear discrepancy to the model that we built up. And this, of course, should trigger some policy discussions among donors and further research. I think that's it. Next slide. Yes, thank you.
Thank you very much, Anneli. We are making good progress here. People are keep the time limits, so there is space for questions, clarifying questions either now or more in-depth sort of substantive questions later during this session. But could I just ask one question, Anneli, myself, for clarification? I know that CEDA, the humanitarian unit at CEDA, uses a system to sort of assess needs where they also incorporate aspects such as expected level of funding, degree of whether a crisis has been neglected or ignored by donors and so on. Have you looked at that system? Has it been in any way part of your study?
Yeah, so the first studies actually started up as a discussion with the humanitarian division at CEDA on how they measure, what they include, what could be included, and part of, I think also, part of our results formed a basis, not completely, but they made use of it. Now, we choose, when it comes to neglect or neglected crisis, I did not actually include it in the study. It's an important aspect, but on the other hand, if you want to make use of this type of tool, the idea was that let's make it broad enough, and then I think from my perspective, it can never be a tool on its own. Of course, you need to put it into a context, right? And there, the neglect can be an extra layer of I mean, that forms the ground for the discussion, because it is important, of course.
Yeah. I think, and you discussed that also more in depth in your thesis. Thank you, Anneli. The Q&A box is completely empty, so I take it that this was a very clear presentation and no need for clarification at this stage. So thank you, and we will move on now to Dell Saulnier, who defended her thesis called Towards Health Systems Resilience to Extreme Weather Events, Managing Health Needs During Floods in Cambodia. And this, the dissertation was conducted in May 2020 at the Department for Global Health at the Karolinska Institute in Stockholm. So please, Dell, the floor is yours.
Yes, so as you already mentioned, this was examining managing health needs during floods in Cambodia to understand resilience better. And it was not only the work of Karolinska, we did it in collaboration with the National Institute of Public Health in Cambodia. So next slide, please. So we know that as climate change is continuing, extreme weather events like floods are projected to become more frequent and more intense. And you can see in the figure where the blue areas represent a higher frequency for severe river flooding by the end of this century. And floods are already the most common extreme weather event that happens worldwide. In the last 20 years, they've affected over 2 billion people, and there are currently about 1 billion people living in areas potentially exposed to floods. So when you combine that with how much they can harm health and the health system, both through contact with floodwater or indirectly through effects on things like infrastructure, resources, access to health care, disruption of livelihoods, and so on, they can have quite a strong burden on both. And they can shock the health system by increasing both the demand for services or in decreasing the available resources through the effects that I just mentioned. And this can challenge the system's capacity to actually continue delivering services. And these are services both for new needs that are caused by the flood and also routine needs that are going to continue to happen regardless of whether there's a flood or not. So this could be things like management of chronic conditions like HIV/AIDS or prevention of malaria transmission. So what you want is a health system that's able to maintain services for both of these kinds of needs, because clearly if your system isn't functioning, needs can go unmet, and this can cause additional harm. So your health system needs to be able to respond to these shocks and change when necessary. Next slide, please. And this is really describing the concept of health systems resilience, which is broadly understood as the capacity of a system to adjust in response to a shock, while also retaining control over its structures and functions. And I understand that this framework is a little bit difficult to read on these slides, so I will talk through some points here. But essentially, the theory goes that there are 3 different capacities in these boxes here, where a system, when it's faced with a shock, can either absorb the shock without changing, adapt in response to the shock, or fundamentally transform the function or structure of the system so that the shock is no longer relevant. However, this concept is still pretty new to health systems. It's quite common in other disciplines, and so far there hasn't been that much research that really can show what characteristics or processes or strategies actually promote resilience in a system. But from the sort of conceptual beginning, somebody named Blanchette designed this framework here, which suggests that these 3 capacities to absorb, adapt, or transform, which is really where you get resilience, are derived from 4 other capacities. And these are knowledge, which is really about how knowledge from inside and beyond the health system is integrated and processed. Uncertainty, which is how the system anticipates and copes with uncertainty. Interdependence, or how the system manages interactions with other systems beyond the health system alone. And legitimacy, which is if the system is able to actually provide socially and contextually appropriate care. And importantly, this really includes the population's actions to manage their own health needs. We know that resilience in theory is shaped by relationships and interactions inside and outside the health system. And community members are both beneficiaries of health services, but also co-producers of their own health. So how they manage their health needs may actually influence the system's own capacities to be resilient. Next slide. So what we wanted to do, in effect, and I will actually only present 3 of the 4 studies from my thesis here, but I'll go into detail on these 3, was to see how well a specific health system, the one in Cambodia, coped with floods, to be able to identify what actually helps build resilience. And resilience really needs to be contextualized to a particular setting to understand these capacities. And we chose Cambodia because it is an opportunity to study the effects of predictable and repeated flooding on health and the health system. In some regions, it floods every year, particularly along the floodplains, and in other regions, it only floods occasionally. So first, we wanted to assess the impact of floods on health to help identify how health needs are expected to change when there is a flood, and so that you can understand how health services might need to change or adapt in response to floods. So we looked at the short and long-term impact of floods using a time series analysis. And then to really understand what capacities might be driving resilience or creating resilience in this context, we looked at the capacity of both the community and the health system and how they both manage health needs. So a very similar study, but from 2 different perspectives. So first, we looked at the community to understand the link between the community resilience and the health system resilience, looking at community members who had experience managing pregnancy or birth care during floods. And then we looked at the provider perspective, so either providers or decision makers working with maternal health services during floods. Next slide. So I mentioned just a brief bit about Cambodia, which is where the study was set. It was done in 2 rural districts in the southern part of the country, one on the right-hand side, on the right arrow, that floods occasionally, that floods every year, seasonally every year. And the province on the left is one that floods occasionally. And Cambodia has a decentralized health system, meaning the majority of services are delivered at health centers and hospitals at the district level and managed by district health departments. It also has a wide and fairly unregulated private sector. We only included public healthcare facilities in this research, but we also know that private providers are predominantly the first point of care. And that's with the exception of maternal health services, where most people actually use public services for maternal health. And during the last 15 years, the health system has really promoted emergency preparedness, and this includes developing plans on how to respond to extreme weather events. Next slide. So a compilation of the main findings from all of these studies is, first, we did see that floods seemed to have a sustained impact on new health needs in this context. We saw diarrhea, acute respiratory infections, and skin infections all increasing immediately during a flood and then up to 3 months afterwards. We also saw that the community appeared capable of absorbing the impact of floods on antenatal and birth care needs, which appeared to help actually relieve the burden on the health system for them to have to manage. They still, though, the community had to balance the expectations placed on them to receive formal care, but with little support or help. So pregnancy and birth were quite difficult during floods, and most of the community members wanted the security of having formal care from the public health sector, despite some mistrust in public sector care. At the same time, they felt pressured by village leaders and the health centers and the health departments to actually go to the facilities and receive this care. But during floods, access was quite difficult, and they had few resources and very little support from the health system or from other organizations or sectors to go and access this care and receive it themselves. So the majority of that responsibility fell onto them. From the health services side, we saw that the maternal health services appeared to be able to absorb and adapt when they were exposed to repeated floods. And in this context, it was sort of described that floods to the health system weren't really seen as a challenge compared to many of the chronic issues that they faced anyway, like a lack of staff or chronic underfunding or under-resourcing. And their ability to absorb and adapt seemed to be related to collaboration and relationships that put a boundary around the decisions that they could make. And this seemed to allow them to be able to respond in a stable but flexible way. So their previous experiences with floods let them be able to adjust plans that they already had to whatever flood scenario was presenting itself that year, and then make decisions that they knew that they were allowed to make within their roles. So for example, as a midwife or as a health department staff, what decisions did they know that they could make? And these boundaries seem to be defined by collaboration and relationships, both with other levels of the health system, so from health center to hospital or hospital to health department, and with other sectors and with the community. And this really helped information sharing about health and floods, and also to keep the services functioning. Next slide. So in terms of floods as a shock to health and the health system, in this context, the increase in visits for diarrhea and infections might be linked to local risk factors and therefore may not be relevant to floods in other contexts. And these risk factors could be things like lack of sanitation facilities or access to clean drinking water during floods, which these factors remain pretty high in Cambodia. The private sector is also likely a very important source of care for both new and routine needs. Although we weren't really able to capture that, we tried to look at routine health needs by looking at, for example, the number of visits for non-communicable diseases like heart disease or diabetes that were conducted in public facilities during floods. But there was just too little data to actually analyze, because primarily people don't go to the public healthcare facilities for non-communicable diseases. So there wasn't enough information to actually show that relationship. Also, that repeated exposure to floods might actually be generating some strategies for managing these health needs at home without actually needing to seek facility-based care. And this is evidenced in part by a delayed increase in visits for up to 3 months after exposure. And also, interestingly, health services were described as available and accessible, which implies that they may not be restricted by floods in this context, which might have something to do with the fact that these floods are repeated. Next slide. And then when we come to the actual capacities of resilience, what does this mean? What did we learn? The community and the public sector both had some capacity to absorb and adapt. Transformation, the capacity to transform, was much harder to actually identify in this work for a variety of different reasons that I can discuss later if you want. It's also relevant to consider the community and the health system capacities together. The community capacity seems to really be relieving the burden on the health services. And it's still unclear how their resilience is, how closely linked their resilience is to the health system's resilience. However, their capacity could be at risk without support from the health system. we came across very few investments to relieve the burden on managing health needs on the community. So for example, referrals between facilities were dependent on the patient being able to complete that referral. There weren't many ambulances or anything that could do the referral for them, so that was the community's responsibility. So more severe, different types of shocks might actually overwhelm the community's capacity to deal with these events, shifting the responsibility fully to the health system, which will have implications. The community also regularly described feeling sort of powerless and unable to make their desired choices around care during floods, creating this loss of trust and sense of very little ownership in the health system. So addressing this sense of trust and ownership might actually create the capacity for legitimacy and interdependence, which were two of the dimensions of resilience I described earlier. And interestingly, we also saw that limits on decision-making appeared to affect the community and the health system differently. So in the community, these narrow choices for managing pregnancy and birth care were the ones that were affecting trust and ownership. It also means that the community might have lost some alternatives for coping during floods. So for example, using traditional birth attendants to ask for advice about how to seek care from public health facilities. And it could be that this loss of power and exclusion from decision-making is what's influencing the community's ability to primarily absorb rather than adapt or transform. And in the health system, though, alternatively, the limits appeared to be what was sort of driving the system's ability to be stable and flexible and let people make decisions if they knew that they were acceptable. It appeared to be sort of a way to counteract uncertainty by giving participants power to make choices that were supported by higher levels of the health system. Next slide. So some suggested implications from this, beyond more research, is to really understand context as a driving factor in resilience. We know this from other disciplines, but to consider whether suggested strategies for resilience, health systems resilience, that we know will be coming up more frequently now, are likely to actually be effective or acceptable in another context. I think addressing the role of the community and trying to link them to the health system when it comes to shocks like extreme weather events and floods is extremely important. So at the local level, this could mean working with communities to understand how their management of health needs could be incorporated into the health system response. So what are they already doing that the health system could build on? And also to identify gaps in their management that could be filled by the health system. So for example, going back to this idea of referrals, how could the health system fill that gap in a better way? And doing this might actually promote more trust and ownership in the health system, which was clearly lacking from our results. And then also we come to this idea of repeated exposure to the same shock or to similar shocks. So this may be one of the reasons for considering the role of repetition in strengthening the capacity for both the community and the health system to absorb, adapt, and transform. And this may be particularly important if climate change is expected to create repeated exposures gradually to different types of extreme weather events. And that was all. So next slide just says thank you.
Thank you very much, Dell. A really interesting account of what recurrent emergencies in a country like Cambodia means for people, for communities, and for systems. I'll ask each one of you a question, but I just want to see if there's anyone who would like to ask a clarifying question before that. It's an empty Q&A function, so let's go ahead. And let me begin then again with Jenni talking about Mozambique. And of course, you describe a very complex system. You describe this, you analyze this in terms of policy subsystems with the many different actors that have sort of different motivations and role in the system. And you've identified and you sort of grouped what you call competing advocacy coalitions, which I think is a very interesting and sort of helpful way of understanding the complexity and the issues at hand here. One thing that you particularly mentioned, and also Dell talked about this as well, the fact that an emergency disaster is a learning opportunity. Things will happen, some expected, some unexpected. But it seems that we are, and I think this is not only a question in Cambodia and Mozambique, I think it's the same thing in Sweden when we have forest fires or floods and so on. There seems to be a poor ability or sort of a lack of intended using experiences for learning. And you point particularly to the issue of the frequent and rapid staff turnover in Cambodia as a special obstacle and a problem linked to that. And I wonder if you could say a few more things about, so how could that kind of problem be overcome? What could the Cambodian government or the Mozambican government do to ensure that these learning opportunities are really used and exploited? So I'll ask you to come back in a minute, but I'll ask each one of you a question now, and then I'll come back to you, Jenni. So Anneli, looking at this perennial and very difficult question of assessing needs and estimating needs in a way that they can actually guide operations and asks for resources. You point to the fact that there seems to be a discrepancy between actual needs as we understand them and what agencies, the UN in particular, is actually asking for in terms of resources. And you point out that there is a discrepancy. Some emergencies seem to be, there's an unbalance. So in some emergencies, and I think Syria is the sort of specific case here, the UN will ask for much more resources per capita than in other emergencies, and it may be difficult to sort of understand exactly why is this, what is the reason for that. So if you could say a few words about how should we understand it, have you been able to sort of analyze what is the difference between these kinds of appeals when the ask from the UN is so different for different emergencies? And you sort of indicate that there may be other considerations at hand that lead to this result. And then finally to Dell, looking at how people and the health system interacts in Cambodia, and you point out the fact that there's a sort of there's a degree of mistrust between people and the government system, which I think may not be only a question of a mistrust in the health system, but also other parts of governance in Cambodia, which may partly have historic reasons, given the sort of deep trauma that the Cambodian people has gone through in modern times. And you then point to the need for the health system to better understand people's own strategies in meeting their need for care and so on, and you have some suggestions on how that could be done. Could you say a bit more about that? What kinds of actions, what kinds of outreach is needed from the government to help build or bridge this trust gap and to sort of understand and build more on people's own strategies in meeting their health needs? So sorry for my maybe a little long questions, but could we begin with Jenni then talking about Mozambique and the learning issues?
Yeah, thank you. I think it's a good question, and I think it's very difficult. I think one thing is that many organizations and government now after disaster event puts together these lessons learned sort of documents. But what I've seen often they are sort of filed. It's almost like a box ticking exercise, and they're put aside. And then next disaster come, maybe there's new people in the office, and no one goes back to those documents necessarily. So I think what I would like to see would be some sort of more systematic way to really find a few sort of key points after each whether it's just a disaster, but what led to this, or what can we learn, what sort of mistakes we should not repeat, and try to actively implement them, or like take them in the system, so that the lessons are not forgotten. And I think it's the same goes to, as I mentioned, the staff turnover, that people are moving a lot, and so then it easily happens that knowledge is produced and it is there, but it gets lost. It's sort of filed away, or it moves away. And again, I'd like to see some sort of more better way to transfer the knowledge from one person to another and one organization to another, to make it more resilient, if you like, that we do not lose the knowledge. But I mean, yeah, it's very difficult issue for the people involved.
Yeah, and again, I think we're not too good at that ourselves in the Swedish system.
No, absolutely. I think it's the same thing everywhere.
So what you're talking about is really, you need to sort of build into the disaster management way of working this kind of learning events, but also there has to be a preparedness to receive that learning and use it and use it for change, which may be something that has to sort of move between levels in this complex system.
Exactly. Yeah. Yeah.
Okay.
The knowledge, what happens actually on the field, needs to go on to the national level.
Yeah. So work to be done. Work remains to be done. And maybe something also for donors who are involved in supporting DRR in countries could also think about.
Yeah.
So we have a neglected need here that needs work.
Absolutely.
Thank you, Jenni. So, Anneli, what about this discrepancy between what agencies are actually asking for and what may be the actual needs of people? How do you see that?
Yeah, well, it is. I mean, that's really the key question, isn't it? And I'd like to come back to something that I wrote in my thesis, but is actually not part of the EBA report, because it was more of my own personal experiences from working in all sorts of different disaster situations. And sometimes in Sierra Leone in the late 90s, with an extreme lack of resources and actors in other places such as East Timor or Niger in 2005, with many actors coming in. And just to say that I never saw situations where actors were sort of producing or suggesting needs that weren't there. So I'm not saying that we're not working to meet needs, right? But the problem is that it's so unevenly spread out when it comes to the resources and the efforts. And it is difficult, I think, to explain why in some contexts we ask for assistance that amounts to more than double what we do in other instances, right? And I think it has to do with, of course, it has to do with the cost and the level of living conditions, what you actually can do. And maybe it costs a lot more to provide assistance in a middle-income country compared to one of the poorest countries. You can question that. Is it ethical? Shouldn't we be basing our assistance on the sphere standards? And if people already are up to the sphere standards, then why should we be providing aid? That's other questions, but I think it has something to do with it. And then I think, despite the good humanitarian donorship, despite everything we say, of course, the geopolitical interests are interfering. And of course, there are, in situations where there are many actors, we will discover a lot of needs. And in other places where very few are active, then the needs won't even be mentioned, right? And discussing with the UNOCHA, for instance, and trying to understand how the appeals are being produced, they are very much based on a compilation of organizations, what they discover as needs. And of course, if there are many, we will ask for a lot of money. And if there are few actors, then they will ask for less. So, yeah, to put it harsh.
Yeah. There's an EBA study that we published, I think early last year, which looked at what are the consequences when the appeal, the need of funds are not met. What do agencies do in order to sort of adapt to that kind of situation? And there was an indication that since funding always seems to be under,
you have to top up, right?
in the field sort of will reduce. They don't expect to get everything they think is needed, so they sort of reduce what they what they ask for. They adapt to a situation of scarcity almost. Could I add to that? Could it be also that the whole, now we are talking very much about sort of material needs in terms of the need of services and food and shelter and all of that, but the protection needs that are particularly high in certain particular conflict, crises related to conflict, etc. May it be that those are sometimes more difficult to sort of assess the costs of protection activities, that they are less prominent in what is being asked for, or maybe even less understood by donors?
Well, this is my own personal view on this, is that sometimes we use humanitarian assistance as an alibi, because it's not the assistance that will protect people, but we know that the protection needs are so high that people are really suffering and dying because of the conflict. So therefore we spend a lot of money, but not necessarily to protect them, but it's sort of an instead of trying to hinder or stop a conflict, that's what we can do basically. So
okay, this debate will continue, I'm sure. Thank you, Anneli. So Dell, again, coming back to Cambodia and this the issue of the interaction between people and people's own strategies when it comes to sort of meeting their health needs and needs of care and the functioning of the health system. How could this gap possibly be bridged, do you think?
Yeah, and I think the idea of trust is quite tricky and is quite tied to ownership. And as you brought up, building trust requires more than, I think, believing that what you create in the normal times when there isn't any type of shock will still apply when there is one, when you're under these extraordinary circumstances, where this sort of rational belief that trust will carry over may not be true. You may, for instance, trust your health system to provide your child with a measles vaccination, but maybe you don't trust them to provide you with a COVID vaccination, for instance. So it's not an inherent, one-on-one analogy of trust. And this is also quite closely tied to the political environment and history, as you mentioned earlier. In Cambodia specifically, I think some of the things that we saw were a very inequitable distribution of resources, quite obviously. And some of these things means that people were required to manage their own health, needed to borrow money or take out loans to have funding to go and seek care, to either buy or rent or borrow a boat if they had somebody that they could do that from, differing levels of health literacy so that people understood when and how they should be seeking care. And also coming back to trust, this idea of a power imbalance where within the villages, oftentimes the formal link between the health system and the village would be the village chief, who of course holds a very powerful and important position. So I think in terms of strategies about what you could actually do about this, I think, there are ongoing accountability strategies for the health system in Cambodia. So for example, health center management committees, which are supposed to meet regularly to address any issues that the community is having with their local health center. But I think that there are ways to sort of strengthen this accountability that could actually build sort of satisfaction and confidence as well as trust, because they're so closely linked, to build quality of services, which should improve people's desire to seek care during floods. I think, for instance, another thing that we saw was to initiate, for instance, outreach for health services during floods when the community desires it rather than when the health system deems it necessary. So we saw, for instance, that during floods, if it became impossible to access the health facility, the health facility would begin outreach services when communicable diseases became important. So when diarrhea cases arose, for instance, but that really neglects a lot of the routine health needs like I was describing. So antenatal care, they still aren't able to access the facility, but it's entirely dependent on them. So in that case, it became much more of a position of the health system saying, this is when we think it's important to provide these services versus what the community actually wanted themselves. And of course, like I said, I mean, this will depend on where you are and which context it in. In Cambodia, these particular things that I've just listed may be important, but if you go to another country or another context, it might be completely different, which is why I think the dialogue with the community is so important.
Again, sort of underlying and emphasizing the fact that everything is highly context related here. We have a couple of questions that both are related to the current COVID crisis. So let me read them to you, and I'll invite any one of you who would like to ask a question, who would like to respond to this, to do so. The first one comes from Nina Paulsen at the Swedish Red Cross, who says that this is a bit long, but I'll read it. So she is noting that the COVID crisis is changing things a lot with regards to funding, also in the initial phase of other disaster-related operations. For example, in the huge cyclone that would have hit Mozambique in 2020 instead of 2019 would have resulted in much less support even at the relief phase. And she and Swedish Red Cross concerned that the current big disasters in Southeast Asia and Central America are going on at this moment gain limited attention and funding. And she assumes that there's a similar situation for even worse for DRR investments. At the same time, DRR activities on all levels, including policy and community-led activities, become even more important. So anyone who would like to comment on that, and we'll link it to a question from Johan von Schreb, who says that, invites anyone to reflect on how their research results could be used to better respond to the short and long-term perspectives in relation to the current COVID disaster. Any advice or to decision makers? So to all three of you, any thoughts, any reflections on your findings in relation to the crisis that we are now facing? Who would like to begin?
I could perhaps start.
Okay.
Yeah, I mean, I've been thinking a lot this rather special 2020, and I've been thinking the same, that it's a blessing in many ways that the big cyclones hit Mozambique last year and not this year. And I think we all see how little attention for example, the Central American disaster is getting at the moment. It appears once and then it's gone again. It seems like the international media only has space for one big disaster at a time, and now it's just COVID and nothing can compete. And I think that obviously affect the funding to any other disasters and more long-term DRR responses. Yeah, it's a sad thing. I think that's actually something that they've learned in Mozambique also, is because funds, the international media is only interested in any disaster for a very short time usually, that they need to be very quick to apply for help and funds very quickly when the disaster hit, because then it's something else. And they won't get any help later. Going to the second question, I think I'm not sure if I have anything to say about that would help this one, but I think if you now think what climate change might bring more and more, this sort of big pandemics, I think this has really been a shock to the system in many countries, and it has revealed a lot of issues and weaknesses in systems that we thought that works fine, and they work fine in normal settings. But when a shock like this comes, we realize that we are quite vulnerable. There are issues I think lessons learned from this can be drawn in terms of, for example, different mandates, who has mandates, how do we coordinate and collaborate our work, and yeah, I think it's the same basically for all countries. I don't think any country were really prepared for a shock like this.
Do you think that Mozambique, that still, I think comparatively has a good reputation in terms of DRR work, and even if there are flaws and deficiencies, it's clearly there's a thought through system and so on. Do you think, or do you have sort of current contacts with the country? Can you see whether the DRR system that has been established, whether it is actually playing a role in the response to COVID as it now unfolds?
Yeah, I don't know that much what's happened in terms of the COVID response. There's also an armed conflict ongoing at the moment, which is I get more on my news feed from there. So no, I can't actually. But I would think that in some ways it helps. It's not the first epidemic there. They are used to dealing with these things.
And obviously, a functioning DRR system needs to be prepared for any kind of emergency, ideally not only floods. So. Yeah. Thank you, Jenni. Can I move on to Anneli? Any thoughts from your side about what you have found and the current crisis?
Yes, I mean, on the question from Johan on what we can learn, I think what one can learn from the studies that I've done is that different hazardous events or different hazards will sort of you can't automatically use the same measurements of vulnerability. So in an earthquake, it might be very different from in a complex emergency, for instance. And I think that is what we've seen also very clearly with COVID, that it's not, the vulnerability and the risks of having a large amount of people being affected and so on has to do with demography. It depends on the aging population, yes or no, etc. So there are other factors than what we usually would think about in terms of vulnerability, and that of course has to be taken into account into the response. I think the second part there, and I'm not sure if it's linked to my research or our experiences, but clearly in highly vulnerable complex emergencies that are relying to a large extent on humanitarian assistance for many of the services. The COVID, not so much maybe the COVID outbreak, but the response and the lack of resources, the difficulties to get assistance in and so on has had very, disastrous effects in some countries, and there, that is something that we could have foreseen, I think, based on the vulnerability, based on the needs, and maybe have been able to mitigate in a better way than has been done.
Thanks. And Dell, the same question to you. And of course, you have looked at the health system, which of course is particularly in focus now.
Yeah, and I think for me, these are sort of from my own research and also from what I've been doing since, there's sort of three things that come up. One of them, again, is this trust, which I've already described a bit before, and what works in normal times in terms of trust may not work now. And I think that's been particularly interesting with COVID, when we have, because it has been a shock that has impacted all sectors of the country. So to maintain this, we've needed to include education and the economy and finance and so many different sectors, that the government is really the only organization, for lack of a better word, or system within a country that has the legitimacy to actually respond to COVID. And when you have things like these contact tracing apps, it raises a lot of questions about how much do you trust what's going to be done with this data. And I think that there's all these new questions that COVID are rising, but a lot of them sort of have this fundamental idea of trust underneath, and how much can you trust who or what is responding, including the health system. And I think this comes back to the idea of what is it that the health system needs to do to adjust trust to be able to actually respond. And you see this in some places where now people are implementing fines if you break some of the restrictions. And that is, I think, a health system response to the level of trust. But is that the ideal way for the health system to respond? I don't think so, in my own opinion. I also think it comes back to a few other things. One of them is what, as Jenni was pointing out, what can you actually learn? I think a lot of what's been done now that it's been a year into the COVID pandemic, a lot of systems have been focusing on, understandably, very quickly, what can we do right now to make this sustainable or to deal with this problem? But I think the shift needs to really focus to what is it that what allows us to actually change in response to this? Because I think it's the long-term solutions that are going to prevent something like this from happening again. So, improving equity, for instance, we've seen differences in mortality and morbidity depending on different groups of populations and the impact of restrictions on people. So I think these sort of long-term transformative strategies are what's going to be needed. And I think we need to learn now how and why systems are or aren't able to actually change.
Yeah, important. And I think now, clearly, this time, there are already learning analysis evaluations underway or being planned, including by OECD DAC, led by OECD DAC, and many countries are already involved in that. So I think there will be sort of opportunities with much support to actually analyze and learn what has happened. And as has been pointed out by you and others, climate change increases the risk that we will see pandemics again, a high risk which was already there, but is now even heightened by the impacts of climate change. We have one more question. Let me read it to you, which comes from Elizabeth Narrow at CEDA. So she says that humanitarian assistance is more and more used to try to compensate for failed states, needs in failed states, which are clearly not only humanitarian. This was before the IMF and World Bank's used to be their arena. How should the humanitarian community relate to support in these kinds of very huge and complex crises? And she mentions Venezuela and Zimbabwe in particular. So this, now we are entering the sort of the difficult nexus issue, and again the humanitarian sector is being asked to do things which it often feels it is not equipped for or really not mandated to do, but nevertheless it finds itself in a situation where it has difficulties sort of staying away from that because there is no one else taking action. Who would like to comment on this issue?
Maybe I should. No, but I thanks, Elizabeth. I completely see your point, and the same. It's not completely new, is it? And we've had the same discussion around the occupied Palestinian areas some years back, and so on and so forth. I mean, why is this a humanitarian issue or a humanitarian responsibility? I mean, from my perspective, it's. If we look at the vulnerability, if we look at the number of people affected, if we see that the government is not willing or capable to cater for the life and the well-being of people, then and no one else is doing it. That's why we have the humanitarian assistance. So I think we have you have a responsibility to react and act when it comes to Venezuela, just as much as the Central African Republic, because if there is, the hazardous event can be man-made and it can be a conflict, but it can also be this type of completely that a government do not care or actually see its own population as enemies and handle it accordingly. And of course, it is also humanitarian responsibility when it comes to the level of increased health problems, excess mortality, and people being without needs.
Thanks, I don't see any new questions at this point in the Q&A or chat boxes. I'll invite the three of you again you've listened to your colleagues here. And again, I really think we've been fortunate because you've all sort of highlighted different aspects, different dimensions of crisis and how societies deal with crisis. Is there anything that you sort of have found particularly relevant or of interest and which sort of may shed light on your own work, your own research? And I'll go again ask the three of you, beginning with Jenni in Karlstad. Please, Jenni, anything in particular you've noted?
I think, well, a few things. I think, well, if I start with Anneli's work, I think as I was reading it, and when you talked excess mortality as an indicator, and then I was writing a note. But what about slow onset disasters? But then you got into that in your discussion. I really like that discussion. I think it just goes to show that we can't. Not all the disasters are the same. We need to have not just one tool, but rather a toolbox of different indicators and things. How we, what are we looking? What kind of indicators are we looking? See the needs, for example. I don't know how close that's related to my work, but that was something that I really started thinking a lot when I was reading your work. Dell's work, I think there were certainly similarities to my work in terms of issues like trust and transparency, for example, and the community engagement was something that I thought was really important. What did I write here? Yeah, one thing I was thinking there was, I mean, you mentioned a little bit of climate change, but I was really thinking that as the risks may change quite rapidly with climate change, they might be facing completely new types of risks as well, which I think is important so that they know how to deal with not just when sort of one type of shock comes, but that it might be something completely different at another time. I think that was the main thing. Thanks.
And Jenni, there's someone has written a pretty long question in the Q&A box, which we will not have time to go through it all, but I encourage you to take a look at that, and maybe the person asking the question can reach you if you want to follow up that conversation. So moving to Anneli, anything that you have found of particular relevance and interest to listening to your colleagues?
Of course, I mean, very, very interesting, both of your studies and results. And I think they are in many ways complementary to one another, looking at disaster risk reduction and resilience. And so if I look at it from the perspective of the studies I have done, I think they also, I mean, what I think my part can contribute with is perhaps this outcome studies or the, you know, the vulnerability. There's one thing to look at the resilience. There's one thing to try to understand how disaster risk reduction can be improved, but we also need to look at the results after. Was there, you know, what's the outcome? What's the excess mortality? How did it actually turn out in the end, to be able to understand better? That's one thing. And then I think in many ways, what you have been looking at is the how and resistance to whom, right? It's because I've been painting very broad strokes of saying that the needs are higher here than there. But of course, I mean, if we really want to have results, we need to look at how assistance is being distributed and by whom? And I mean, you raised a very important point of staff turnover in Mozambique, and I assume, I mean, that can be both national, but also we know that in the humanitarian sector, the high turnover of international staff is sort of sometimes killing the capacity building and the possibility for a country and a population to respond in a good way after. So I think it's very, I mean, yeah, my studies without yours are sort of meaningless because they really, in many ways, go together. I think if we really want to achieve safer populations, better survival, and sort of the good in the long run.
Thank you, Anneli. Can I ask just very briefly, you mentioned the new initiative Inform that you are part of, with a whole set of actors, stakeholders trying to sort of develop and improve the system. And I think this is one of the outcomes of the grand bargain. Could you say just a couple of words of where does this stand now? Is it something, is Sweden involved as a donor, or sort of?
I don't know. I think so. Yes. That's a good question. Maybe it's for Elizabeth actually. But so I've been supporting, being part of developing this crisis severity index. Did you all freeze? So can you hear me? Yeah.
I can hear you. You are frozen, but I can hear you. Yeah, it seems, yes, Anneli is frozen and we cannot hear her. Let's pause Anneli for the moment and then move on to Dell, because Dell, you seem very thawed.
I'm still here.
So please, any thoughts about your colleagues' work?
Yes, sure. I think one of the theme that sort of unites everything that all three of us have been doing is this idea of governance in different ways. I mean, very explicitly in Jenni's work, and in mine and in Anneli's as well, but getting to this idea of who is actually making these decisions and why, and what is the process for making these decisions, whether it's the health system responding to a flood, or deciding where need should be allocated, or deciding, you know, how different sectors will work together to reduce disaster risk. And I think it's a very complicated issue. It's not an easy one to solve, but I feel that it's a useful area for all of us to continue working in, because if you can sort of pick out some of the key strategies and idea from governance, as it's clear from the presentations here, it will impact a lot of different processes and outcomes and initiatives and all kinds of different things.
Thanks. And I think that's a very good kind of concluding remark, and also something that we at EBA need to reflect on, because obviously the work that you have done also provides very interesting input for our own internal deliberations and discussions, and in terms of what do we need to focus on in terms of analysis and evaluations and so on. So thank you all three very much. This has been a really interesting morning, I think, and I encourage all participants to go and look at the brief, the sort of abbreviated dissertations or theses that you can find on our website. It's not every day that the new doctor will actually summarize his or her work in this very accessible way. So I think these are very useful and interesting documents. In terms of what the EBA will do next, I cannot announce now exactly when our next webinar or seminar will take place, but I encourage you to go and follow our website, and particularly to sign up for our newsletter to keep you informed about coming activities and seminars. And also to note that we have a podcast where we invite people from different areas to discuss analysis or studies that we have conducted. Often very interesting, I have found, and that have become quite popular, it seems. So with those words, thank you all presenters and participants. I wish you a continued good day and hope to see you next time. Thank you and goodbye.